Good. Hi, good afternoon.
Good
Good
afternoon, ma'am.
afternoon. Good afternoon. Thank you.
How have you been?
I'm fine. I'm fine. Just running. My houseboy has walked, not coming back from Bihar. I have one chap who's always been with me, but he needs to get back. His mother's had a fracture of the hip, so looking out for a maid right now.
Oh,
Because with the dogs, I need
yes.
someone.
How is your health, ma'am? You're
I'm
okay?
fine. I'm fine. Good afternoon, Shubha.
Good afternoon,
Welcome.
madam.
Guys, we are having Dr. Shubha Chogle just join us for this one
Good,
lecture. She showed
good
interest.
afternoon, ma'am. Good afternoon,
Good
ma'am. Good
afternoon. Very good
afternoon.
afternoon. Very good afternoon.
So that is the story. Now, listen, I'm just asking you, you may say no to me. Nazneen just made a suggestion last night at 11:30. She says, please, can you switch the time to 3 o'clock? I said, I can't for this Friday. This Thursday is out. But I said, I will ask the gang if they would be interested. No, it's up to you, huh? Nazdin wants it because she says it will be better for me on a Thursday this
For
time.
me, no problem.
Hmm?
Thursday at 3 o'clock for me,
Yeah,
no
but
problem.
Shubha, these girls are also married and have households and they have grandchildren to look after, so they should also be able to make it.
So I have no problem. Whether you make it 3 o'clock, whether you make it 4 o'clock, I have no problem.
That's okay.
Ma'am,
Meena,
it's okay with me as well.
Yeah, it's okay, ma'am.
Parul,
It's okay.
Parizad, unmute. Parizad, unmute. Parizad. She'll come out. Yeah, good afternoon, Parizad. No, there was just a
Problem, ma'am.
You have no problem, you heard me? Yeah. Uh,
Yes, ma'am.
okay. Let's see, Dr. Shanti Naidu. I'm waiting for her to join us. She always comes a little late. And she said she will do her kidney punction, whatever she has with her. And I think she will come on in June. I still haven't asked Jaldeep. I don't think she'll say no to effective communication and skills because he is out on a camp somewhere in the middle of the earth, the magnetic north or something, and let him come back home and I talk to him. We'll wait for who's pending. Dr. Shanti Naidu. We'll wait for a minute. What's the time exactly? Okay, we'll wait for a minute or so, and then we will 3 o'clock will suit us. Nihat, we have to leave at 2. ठीक
You
है.
let me know. You let me know in future.
No, that I will. That I will. Let's see because Nazneen should come on. Let me see what she's the one who, at 11:30 I had that message from her. I said no, let me ask the others. I can't comment. I said at least today though we are doing a Thursday because huh? Yeah, where's Rohana's coming in? Rohana hasn't checked in yet. Parul, thanks for sending her the link. I sent it to her also after you did.
No problem. Most welcome.
Money is coming up, Parul. Ruzbeh. Because this friend of ours, Rohina's classmate, she's down from Australia for a very short time. She's looking after a friend who's undergoing chemo. So she and her cousin want to see me on Saturday for a meal. So I'm taking them to Amar because Rohina Jyots is a vegetarian. So I was wanting to take them to Chinese, but our Chinese room is closed. And I said, okay, I'll take you to Nurani, which is my favorite place for a biryani. But she's saying she's a vegetarian. I forgot about it. So I'm taking them to Amar. Last time I took them 2 months back, she was here. I took her to Swati. But Swati is very, very crowded. There's no privacy as such. She's bringing her cousin along. Yeah, so Rohina hasn't come in, and Dr. Shanti Naidu. Shanti usually joins late. I've sent her a reminder to come on in. Riza, what we can do is we can do it. So you were interested in blood banking. I like I told you frankly, I don't have anything on blood banking by way of a PPT. So maybe we can have one talk, which is a discussion talk, if you're interested, and the others are interested. Would you be interested?
Ma'am, I was just giving a suggestion.
Yeah, but મારી પાસે છે જ નહીં તો હું શું કરું તારા માટે? And I've been quite busy to make
problem,
one.
Ma'am. It was just a suggestion.
But you tell me,
Just a suggestion.
you tell us what you know about blood banking, and we'll add on.
You want
Okay.
me to message you?
Yeah, you let us know. We can have a discussion.
Okay.
Ro usually comes in late, na? So I think, what's the time like?
4 or 5.
You want to put the charge on? You can simultaneously. All right, guys, let's start then. Let's start. It is 4 or 5. Let's start. All right, so this series 5 is a little bit of a mixture of topics, as you have seen, and they were quite interesting. And when Munira and I were going through it, Munira said that, I think, ma'am, you should introduce this because I'm sure it will be of interest to the people. So I said, all right. So this is for the people who have rheumatism, whose joints are disfigured. I'm sure you know people like that, and you know how uncomfortable it is and very painful too. So let's start with anti-CCP, which is a better indicator than the RA test which we run in the labs. All right. So we always ask the question of what is anti-CCP antibody. Anti-CCP antibody stands for anti-cyclic citrullinated peptide antibody. Ooh, very big, so we'll cut it down to CCP. It is a protein produced as part of the process that leads to joint inflammation in rheumatoid arthritis. It's an add-on, and it's a bad add-on. It is a test used to confirm the diagnosis of rheumatic arthritis. At present, anti-CCP antibody is the most specific marker for rheumatoid arthritis. With a specificity of 98%, it is a reliable marker to confirm the diagnosis of rheumatoid arthritis. So usually, we do the agglutination tests, and we say positive, negative, but anti-CCP confirms that yes, the patient does have a problem with the rheumatoid factor. So this is the chemical structure of the, what happened? Okay. Nazdeen, you're in? Yeah, Nazdeen's come on. Okay. All right. Very good. Welcome, Nazdeen. Let's get back to the PPT. We'll talk later. Chale, bata.
Good afternoon, ma'am.
Good afternoon. Good afternoon. Late as usual. Chal. Let's continue. So yeah, this is a nice biochemical structure. Shubha, maybe you'll know more about it than I do. And
No.
it's quite
It's very
complicated.
nicely explained.
So it is arginine, L-arginine, converted to L-citronine. And we've got autoantibodies. It is an autoantibody. So you've got citrullinated vimentin. You've got mutated citrullic acid. You've got cyclic citrullinic peptides. And this makes your anti-CCP, which is highly sensitized and can affect a lot of people. So with the yellows, you've got little blues as well as the reds. Okay? So the history. The presence of autoantibodies against citrullinated proteins in rheumatoid arthritis patients was first described in the mid-1970s when the biochemical basis of antibody reactivity against keratin and filaggrin was investigated. Subsequent studies demonstrated that autoantibodies from RA patients react with series of different citrullinated antigens, including fibrinogen, deaminated Epstein-Barr virus, nuclear antigen 1, vimentin, which is a member of the immediate filament family of the proteins, and this is where the problem comes in. Anti-citrullinated protein antibodies, ACPA, or anti-cyclic citrullinated protein antibody. Shubha, will you please mute? Shubha, mute.
And I am paying only 80 dirhams. Like there is a series every Thursday. She will only
No, this is Nazneen. Nazneen, please mute.
Sorry.
So we said ACPA or anti-cyclic citrullinated protein antibodies, anti-CCP, are autoantibodies. Autoantibodies directed to one or more of the individual's own proteins. This is what it's all about, right? That are frequently detected in the blood of rheumatoid arthritic patients. The main epitope of these antibodies is filaggrin, and there is a cross-reactivity between ACPA and anti-keratin and anti-perinuclear factors. During inflammation, arginine residues in proteins such as vimentin can be enzymatically converted into citrullinic ones, a process called citrullinization. And if their shapes are significantly altered, the proteins may be seen as antigens by the immune system, thereby generating an immune response. ACPA have proved to be powerful biomarkers that allow the diagnosis of rheumatoid arthritis to be made at a very early stage. So it's in July of 2010, the circulaire rheumatoid arthritis classification criteria were introduced. These new classification criteria include ACPA testing, and that is important. So you've got the structure there. Anti-CCP test today is a predictor, an important advance in understanding of the pathogenesis of RA and in improving the ability to diagnose it early is the recognition that RA patients often produce autoantibodies directed against proteins and peptides containing the amino acid citrulline. Citrulline is generated in an inflammatory environment by the modification of amino acid arginine by the enzyme peptidyl arginine deaminase. Autoantibodies against cyclic citrulline are generated by patients with a certain genetic makeup, although citrulline may be detected in inflammatory tissue conditions other than RA without the antibody. Anti-CCP antibody have been found in a serum among up to 10 years before the onset of joint symptoms. Can you beat that? Who later developed RA and may appear somewhat earlier than rheumatoid factor. From 10% to 15% of RA patients remain seronegative for rheumatoid factor throughout the disease course. The interpretation is as follows. Anti-CCP antibody testing can help interpret the significance of an inexplicably high rheumatoid factor titer in the absence of classic RA. In such situations, a negative anti-CCP antibody test suggests a non-rheumatic disorder such as hepatitis C virus infection or endocarditis, whereas a positive anti-CCP antibody test is more consistent with early or even preclinical RA since this RA test. Unlike rheumatoid factor, testing is generally negative in the setting of infection. In a new patient with symptoms and signs compatible with early RA, that is duration of less than 6 months, anti-CCP antibody testing is a better test because it has equal or greater sensitivity, especially early on, and a greater specificity than rheumatoid factor testing. Thus, the clinician can have more confidence initiating aggressive disease-modifying therapy. However, in a patient who has documented RA and who is seropositive for rheumatoid factor, anti-CCP antibody testing has limited value. See that? Has documented RA of a seropositive rheumatoid factor, anti-CCP antibody testing has limited value as the information it provides may be redundant. In a patient with low or intermediate probability of RA and with negative or low levels of rheumatoid factor, a positive anti-CCP antibody test helps confirm the diagnosis. Rheumatoid factor positivity and anti-CCP antibody positivity are each associated with more severe RA. Neither test varies with the activity of the RA. Finally, in smokers with particular genotype, the presence of anti-CCP antibody predicts a particularly worse cause of the RA. So we're coming to RA factor and we're asking what is it? Also known as the stiff person syndrome, because you've got problems with your joints and bones, and walking becomes a problem. Rheumatoid factor, first described in 1940, is an antibody against the Fc portion of the immunological values. The cutoff value of positivity varies by laboratory and is usually greater than 45 IU per ml of enzymatic linked immunosorbent assay or laser nephelometry, or greater than 1 in 80 by latex fixation. However, serum titers or serum level expressed as IU per ml cannot accurately be compared between laboratories. When using tests for rheumatoid factor, physicians could refer to specificity and sensitivity measurements for each of the analyzing laboratories. Somebody's there? Has somebody come in? Just a moment, guys. We'll just check. Who's that? No, I saw something. Just a moment. नीचे जाओ. कौन है? Yes. I don't know. Ruainak, okay, come on in. All right, let's go back to the. You admitted her, no? Huh? All right. We'll go back to the PPT. All right. One more? Who? Somebody coming in? Alright, so we said, what is this RA factor testing? Rheumatoid factor, first described in 1940, is an antibody against the Fc portion of the immunological figure. The cutoff value of positivity varies by laboratory and is usually greater than 45 IU per ml by enzymatic ELISA test or laser nephelometry, or greater than 180 by latex fixation. However, serum titers or serum level expressed as IU per ml cannot accurately be compared between laboratories. Instead, when using tests for rheumatoid factor, physicians should refer to specificity and sensitivity measurements for each analyzing laboratory. Around 50% of patients with RA become positive for rheumatoid factor in the first 3 months, and 85% become positive over the first 2 years. Also, rheumatoid factor testing suffers from low specificity since it can be detected, although sometimes the low levels, in a variety of infections and inflammatory conditions such as bacterial endocarditis, malaria, etc. So there is a cross reactivity. So here we have, you have the cell influx and death, you've got the inflammatory leading to pro-inflammatory cytokines and so on, eventually coming into anti-CCP antibodies and so on. Further RA testing, around 50% of patients with RA become positive for rheumatoid factor in the first 6 months, and 85% become positive over 2 years. I think we've done this, all right? Anyway, also rheumatoid factor testing suffers from low specificity since it can be detected, although sometimes in low levels, in a variety of infections and inflammatory conditions such as bacterial endocarditis. The classification criteria for RA, published in 2010 by American College of Rheumatology and the European League Against Rheumatism, provide references for the measurement of rheumatoid factor. Low level positive refers to values less than or equal to 3 times the upper limit of normal of a particular laboratory. High level positivity refers to values more than 3 times the upper limit of the what's there in the lab. This is an attempt to provide a clinically useful benchmark for the measurement of rheumatoid factor, the values of which may vary between labs. So here you've got the latex test below, and we know that any time the latex test is positive, you have to do a titer, and the highest titer giving you visible agglutination is the titer multiplied by the strength of your latex will give you an approximate value of the RA factor. So take a look at this rheumatoid factor and see the image. It's like a mirror image, right? The anti-cyclic citrullinated peptide, right? And that's the reason why your body the attachment, the fight between the two take place. And take a look at that little X-ray of the person's fingers. See what it has done, see where the deposits are, and the fingers are completely deformed. See the comparison between RA and CCP. There are many studies to prove the efficiency of anti-CCP over RA factor. The first one study says, in the study of 826 US veterans with RA, 75% tested positive for anti-CCP antibody and 80% were positive for rheumatoid factor. It was found that a higher anti-CCP antibody titer was associated with increased disease activity and inversely correlated with remission, especially in those also positive for rheumatoid factor. In view of the evidence from these studies, it is surprising that in 210 collaborative classification of RA of the American College of Rheumatology and the European League Against Rheumatism places equal weight on anti-CCP antibody testing and the rheumatoid factor testing in the early diagnosis of RA. And you can see how the bone deterioration takes place. Stage 1, study it for some time. Stage 2, stage 3, and look at stage 4. The bones are completely merged. And you can understand that if they are merged into stage 4, what is your mobility? Yeah, so you have the stiff person syndrome. Take a look at stage 1, stage 2, stage 3, and stage 4. If you will study it, you can see what is happening. Stage 1 is rheumatoid arthritis and synovial. So your synovial fluid is there and it suddenly starts to disappear. And see how the deterioration of the joints takes place in stage 2. Stage 3, you can see there is a merger and pulling. And look at stage 4. All right, I'll go further. So genetics and RA disease, in recent years, there has been a growing recognition that the pathogenesis of RA in patients who are seropositive for rheumatoid factor or anti-CCP antibody is different from the pathogenesis of RA in patients who are seronegative for rheumatoid factor and anti-CCP antibody. This may help guide therapy. Patients positive for rheumatoid factor or anti-CCP antibody who have a specific allelic subset of a region of immune response gene, and there you have the number DRBI04, appears to be highly vulnerable to smoking as an environmental trigger of worsening RA. Patients positive for anti-CCP antibody tend also to have severe joint destructions, you've seen that, and hence have a worse prognosis. Kletthauser et al. That found that determining the presence of a shaped epitope, you saw that, of RA specific genetic marker and positivity for anti-CCP antibody facilitates prediction of the disease cause and prognosis. So you've all seen that epitope, how similar they are. Studies have shown that patients with confirmed RA who test positive for anti-CCP antibody may also have more extra articular manifestations. Okay. Oh, we go here, we got a cartilage, and you've seen how the anti-CCP works into play. This is all immunology related, okay? And you've seen the disfigurement of the person's fingers and bones of the hand and foot. How inconvenient it is, and I've had patients who have very similar symptoms. I have a right, my right toe is cut into half because of a sinus, and that led to my little middle finger of my toe is very similar to. Can you see? If you can see this figure, right? Can you see this? Only one finger is like that. And it's a little inconvenient at times. Otherwise, all the other fingers, everything's fine. So you've got the reference ranges. So at the Mayo Clinic, says anti-CCP antibodies are an important tool for diagnosis of rheumatoid factor arthritis. Similar sensitivity as compared to RF, improved specificity over RF, must be interpreted in conjunction with other information, clinical presentations, and other serological findings. All right, so here we go. Less than, come up here. Less than 20, negative. Low, weak titers between 20 and 39. Moderate positive between 40 and 59, high strong positive over 60%, and it is in European units. Okay, all right. So this is the presentation of anti-CCP and RA. Maybe quite a few of you are familiar, and for some of you it may be a new presentation. Meena, anybody in your family having this?
No, ma'am.
Rohina?
But it was good information for us, ma'am.
Yeah, I know.
Something new for us.
We were going through it, Monira and I, and she said she went through it and says, "Ma'am, why don't you present this? Because this is a little bit of an oddball, and I think we have RA tests every week. A small lab like ours, we have RA tests every week, and we do have anti-CCP, which we send out to Metropolis. We don't do it ourselves, and the results have tallied pretty well. And especially, it's strange that not only do they ask for a regular person who's over 40, 50, 60, they ask for this test for pregnant women. Shobha, you have any information to give us on this? You have any information to give us on anti-CCP and RA in your practice? You know, Dr. Shobha was chief of biochemistry at Bridge Candy Hospital for many years, and she is very, very intimately linked to the DCA class for many, many years, and we are very thankful for the help and advice. And yes, Shobha, tell me.
It's a wonderful presentation. Number one, I'll tell you, my sister recently underwent a knee replacement surgery.
Anji.
When at Bridge Candy Hospital,
Anji.
I had done her anti-CCP and rheumatoid factor as well as RA. So that time she was treated by Dr. Mala Bhambani, the rheumatologist at
Correct.
Ruzbeh, and she said to do this anti-CCP test. This anti-CCP test was high that time. Her rheumatoid factor and RA was negative, but her anti-CCP was positive. Then she treated her with hydroxychloroquine, and that gave a remission to this positive anti-CCP. After that, she started getting problem in walking. Means she used to get a severe kind of sprain kind of feeling in her knee, and it was very painful. So she was not able to walk a little distance also. Then I consulted first. Genicular nerve block was done for her by a pain management doctor, but it was not successful. Though I spent 3,50,000 rupees, it was not successful. Then after that, I consulted a surgeon, knee replacement surgeon. So he said both the knees have to be operated, which was wrong. Only the right knee was facing that problem. Those 4 stages which you have shown, they are very beautiful. Very beautiful. Like first where you said that the synovial fluid shrinkage and inflammation of the synovial membrane. Then after that you have shown the second stage where there is necrosis of the joint, then the fibrous connective tissue presence, and then the touching of the 2 bones. So that was the time when the X-ray told us that for right knee she has to undergo a knee replacement surgery. Then I consulted Dr. Pilankar, Samir Pilankar, who is a robotic and a very famous joint replacement surgeon. He is a teacher also where he visits Germany, Switzerland, etc. And he said no, only one knee replacement is required. And he did it at Criticare Juhu. Now she's perfectly fine.
Great,
So
great.
4 stages which you showed, that last picture which you showed, similar picture was seen in her X-ray just before the surgery. Then she went into a total knee replacement where an implant was put and which widened the gap between those 2 bones. And now she is perfectly fine, but requires physiotherapy regularly, which she has to do. Then you have also shown beautifully those titers, how a negative picture looks and how the positive picture looks. 1:80 you said, that is perfect. And whatever value she had much before when I was at Rich Candy, her value was somewhere like 140 or something, if I am mistaken not. Because you said that anti-CCP value more than 60 is positive. So she had a value of like somewhere like 140 or so international units. Then Mala gave her this hydroxychloroquine, which is even considered as an anti-malarial. But it gives remission with this value. So her anti-CCP came down and it remained normal for quite some time. But in this genicular nerve
RA was still
pain
positive.
treatment surgeon told to do an anti-CCP, it was little bit on a higher side. Means I think it comes down with the treatment, then it starts going up.
Again.
And if it goes up more, that means it is a benchmark that the person's osteoarthritis has started. It correlated well with the bone density, where she had bone density scan, where she had absolutely a osteoporotic level. That is, it was minus 3.9 T value, T score. Now that the post-surgical picture was a very nice picture where the 2 bones were separated due to the implant. So I appreciate those 4 stages which you have given. You have also mentioned well that rheumatoid factor is positive in many other cases also, like in hepatitis, in myocarditis, because it's actually a acute phase reaction. And you have also said that the presence of these cytokines like tumor necrosis factor alpha, interleukin 1 and all that, and that is where the inflammation starts. One more thing you have also said beautifully, that that citrullination, arginine converted to citrulline, and citrullination is the important process. Then you have said that with the enzyme, you have said peptidyl arginine deaminase. So that enzyme also is required for the citrullination. Citrullination is the process where these anti-CCP antibodies are created, because this anti-CCP antibody, because that is actually the phase when the citrullination process is aggravated, then in that case, what happens is the anti-CCP antigens are formed, and to attack these antigens, the antibodies are created. So when the anti-CCP antibody goes up in case of acute inflammation of that this synovial membrane, etc., where those two bones, that means the anti-CCP is the marker in the present scenario for testing rheumatoid arthritis. RAC, my sister's case, RA was negative, but anti-CCP was positive. So how it had predicted that in future she will definitely get 100% bone necrosis, which happened in her right knee. So it's a very beautiful presentation, especially very important to the students who are new. And nowadays, I feel that even at a younger age, this rheumatoid arthritis is there, because I know one of my this clerical staff, her son was only 15 years old, or rather even lesser than that, but he had strong RA positive, he had strong anti-CCP positive, and he was taking treatment of, now I forgot the name of that rheumatologist, but he was taking steroids, he was taking this new treatment for, and I think now he is absolutely okay. So this anti-CCP is the marker to find out how much is the necrosis going on. More severe, more higher values means more severe necrosis, and more in that phase the patient is. Definitely it goes hand in hand with osteoporosis, it goes hand in hand with severe bone necrosis and severe bone destruction. So the presentation was very beautiful. Rheumatoid factor, as you rightly said, it may be positive, because if you go to a general family doctor, he would not know about this test, and he would suggest only a rheumatoid factor. He would only suggest a rheumatoid arthritis test, that latex agglutination test. But this anti-CCP is the marker, and the need of the hour, which at least the physicians, the MDs should suggest or should prescribe for patients who are in the ongoing stage. Because if it is not done in time, the patient would go worse. Because if you do an anti-CCP test, you would get a proper treatment for that by a rheumatologist.